So think of Covered California, the Exchange, as a shopping mall.
Okay.
And
Good
where
analogy.
Blue Shield is one store like Neiman Marcus
Right.
or Macy's.
So
I don't want to put the high price on
Nordstrom's, please.
or Nordstrom, please. Okay, very good.
Everybody wants Blue Cross or any other
That's right.
insurance agencies could be in that mall.
Yes, that's correct.
Yeah, gotcha.
And
And so
we pick and
LA
choose who's going to be in that
Healthcare,
mall.
LA Care Health Plan's the TJ Maxx.
Oh, yeah.
Value. No.
I got you.
My family loves it.
I know. I love TJ Maxx too.
But then your products, your wares, would that then be the bronze, the silver, or is that incorrect? How would that fit in then?
Yes, that is correct. The bronze, the metal levels are different specific benefit products of part of the Covered California Exchange. Generally speaking, we are offering an HMO product on the small group side and a PPO and an EPO product on the IFP side. So we're offering HMO and PPO products, which, hopefully folks do have some experience with in this room. So it's not as if it's a new insurance product for us, but certainly the fact that we are, contracted with Covered California to provide those is different, and admittedly was a confusing aspect for members and physicians. When you add on top of the fact that our network is different, like you mentioned, our Covered California physician network is about 70% of our what we think of as our full or traditionally our PPO network. And that caused a lot of confusion as well. So something that we have been working hard on and will continue to do so. But admittedly, it's not a dumb question. It's been a major source of confusion for various constituents in the last couple of years with us.
And I just wanted to clarify one more thing for your question was that would it be different to purchase his plan through Covered California or go directly? But if you go through, the only way to get subsidized, to get help with your premium or your copays would be to go through Covered California in the state of California.
That's correct.
we have
The
another
subsidies
question.
cannot be offered by us directly.
Hello, I'm Dr. Richard Allen Williams, and I've been very involved in this whole issue regarding Covered California and know Peter Lee very well and have worked to try to emphasize the importance of Covered California. I just want to first congratulate Dr. Talbert and the ABWP and NEPO and any other organization that's has been involved in putting this program on today. It's very ambitious. The time is not long enough to try to get to the essence of what we want to do today, but we're giving it a try. I wanted to try to cut to the chase on several things that I think we need to focus on in this brief period of time if we can. And first thing is that there's an undercurrent which we haven't even gotten into, obviously because of the time constraints, and that has to do with the fact that all of this is due, all of what we're talking about today is due to the passage of the ACA, the Affordable Care Act, on when it was signed in law on March 23rd, 2010, 5 years ago, just last week. And that really sets the stage for everything that we're talking about now. But the other thing that's underlying our discussions today has to do with the fact that there is a perception that minority patients and doctors are not getting the kind of, let's say, benefits from Obamacare and from the various situations that have been set up in regards to health care coverage. And I think that I want to, just in the last few seconds of my question, to mention some terms which I think I'd like to hear weighed in on by the members of our panel in regards to what meaning they have for the minority patients and doctors that we serve and that we're concerned about in all of this. The first term is narrow networks. I think that's an extremely important term for the health insurers to give us an idea of what your take is on it. Blue Shield, for instance. We want to know what that means to you and what it should mean to us, the narrowing of networks. And we know that network width is different from plan to plan. How does that affect our patients, our minority patients in particular, and our minority doctors? I think it's a very important thing for us to consider. The second term has to do with something that came out in the description that the lady from LA Care gave, and this is a concept of cherry picking, especially when we discuss things like pay for performance, P for P. Are we doing some cherry picking, and how does that affect our minority patients and doctors? If we perhaps perceive that certain patients are being included or excluded, and certain doctors are being dealt with in the same way. Is cherry picking going on? And in fact, is that fair? The third term that I'd like to get you to weigh in on is risk adjustment. That has not been mentioned today, but all of the health insurers know what that means, and certainly the lady who is here from HHS has a perception of that. Is that correct? Mm-hmm. And that's not necessarily the same. You're not on the same page necessarily with all of the health insurers, if I'm getting the concept correct, from the way that you see it versus the way that they see it. But the important thing is what that means to the minority patients and doctors. Risk adjustment. Everybody here needs to understand what that term means and how it affects your practice and your patients. The final thing is what the regulatory function, if there is any, is of Covered California. Can you have an impact on the insurers that will be beneficial to our patients and our doctors? Thank you.
Well,
That's pretty loaded, so
okay.
let me give a crack at it. So,
Be loaded.
just a couple of things. With regards to narrow networks, as previously stated, our existing network for our Medi-Cal population, which represents about 800,000 lives in LA County, mirrors or is identical in terms of networks to our Covered California network. And with our Covered California network, we actually had a few groups that didn't want to participate in Medi-Cal, but did want to participate in that product. So it actually expanded our network for Covered California. But we recognized that there was going to be a degree of churn between Medi-Cal and Covered California as individuals went above and below that 138% of the federal poverty level that Dana mentioned. So we did try to keep them as closely aligned as possible, but given that certain physicians wanted to participate in Covered California and it expanded access to care for individuals, we wanted to make sure that we took that opportunity, and we did so. Secondly, with regards to cherry picking, at LA Care, historically, we have provided for age-sex adjustment factors, which we actually feel has disproportionately caused certain of our plan partners to actually direct members to continue participating in LA Care versus our plan partners. So we feel that we've gone above and beyond to ensure that cherry picking doesn't occur. And in fact, we've accepted and paid according to what we feel is a fair metric to accommodate any additional needs that a patient might have. And with regards to the risk adjustment, I think that we're on the same page as health.
Bianca, could you just slow a minute?
Oh, sure.
Could you just define how you interpret cherry picking? What is cherry picking?
As we understand it, in speaking to our provider network, it would be certain physician groups passing off members to other physician groups because they feel like they might be more time consuming, have mental and behavioral health issues, or have
It'd be more costly.
high needs more costly. So when I say that with regards to our Medi-Cal line of business, what we've done to adjust for that is certain age, sex adjustment factors in addition to our base factor. We've done that. We've provided maternity kick payments. We found those to be very successful in terms of accommodating those patients with higher needs. providing additional payment to physicians to reflect the additional time and expenditure that goes into caring for them. With regards to Covered California, based on the different age levels and based on the different metal levels, silver, bronze, etc., we have adjusted our payments accordingly to try to ensure that those patients that have higher needs based on age and based on sex, you're receiving higher payment accordingly. So we do feel that from an actuarial perspective, we've done all that we can to ensure that if you're going to be spending more time with that patient based on the data and what it suggests, you're being paid accordingly. We want to make sure that our members have access to care, and the only way to do that is ensuring that you're being paid at a level that's sufficient to ensure sustainable relationship between both of us and keep you on our network. Lastly, with regards to the risk adjustment, like I said, we do have experience doing that with regards to...
What is risk adjustment? What do you mean by that?
Certainly. So based on the encounter data we receive and members' risk is adjusted. One is where our base rate is set for members with higher diagnoses. They fall into higher risk categories, and they're paid based on if it's more than one, they have higher needs, and so the payment would go up accordingly. With regards to the way that we view this from and you mentioned Bonnie and kind of the way Health and Human Services sees this, we really just see it as members that have higher needs will be paid higher to the plan, and we pass those payments on to our providers. There's no secret about that. It's very transparent, and that's why we rely so heavily upon our provider network to provide us with good encounter data. Because that encounter data, we don't ask for data just to be a pain in the behind. It's really because our funding is very, very reliant upon having good encounter data. If your members are sicker, your encounter data should reflect that. And when we pass that on to the state and to the federal government, our funding is based upon that as well. So it's really a help us, help you ask when we really reach out multiple times through the year with our provider relations team to ensure that you recognize the importance of getting that encounter data, because it is what we use to justify the funding asks we have of the state and the federal government, and the actuarial estimates that we in basing our capitation payments to our groups.
Do you make a relationship between risk adjustment and cherry picking?
I think that if there's not adequate funding, there definitely could be cherry picking. But if the funding is adequate and you are being paid more for sicker members that are assigned to your group, then there should be no cherry picking, because your payment will be commensurate to the needs and the time that you're spending with that individual. That's a sign of a good system that's working, and that is the goal.
I think my question sort of leads in to his, and mine was going to be much more simple, and that is, where is my money? Because we've talked a lot about the different programs that patients can choose, and we've talked about maintaining quality. And I like to believe I will do a good job regardless, but nothing will get me to behave consistently the way I think I should, like paying me.
Absolutely.
And I'm not quite sure how we work on getting the transparency and being clear that that is as important a part of the equation as are all of these euphemisms that we move around. The patients will be able to get in my door. I'll come in early. If I'm making a great amount of money, I'll drive my Rolls Royce right on up to my office and stay there all day and all night. Now, frankly, I drive my Toyota up there and stay all day or all night. But I should have the right to make not just a decent salary. I should have the right to practice my craft and offer patients well. Now, those real exotic things, nah, not so much. But I want my money.
Where's the money?
And you know what? We're with you in terms of making sure that you're paid according to the care that you're delivering to our members. We absolutely are on the same page, and I'll clap to that as well. We are wholly, at LA Care, I can speak to that, we are wholly reliant upon the state and the federal government for 99% of our funding. And that is where encounter data that we receive from you justifies the funding they give to us and that we can pass on to you. We're a not-for-profit. Our books are open to the public. There's nothing being retained. I can say that we're doing our best to ensure that you, in providing care, are incentivized for doing your craft and doing it well. Our pay-for-performance metrics they're not mysterious or asking you to go above and beyond what the standards of care that have been established by the medical community are. We're really just rewarding physicians for providing the care and reporting it to us, because that's how we're going to be able to pay you more. Above and beyond that, I'm open to suggestions, but it's not a mystery from our perspective how things are derived. It's all actuarial and based upon that encounter data.
And I just wanted to ask two unrelated questions, but getting back to, in terms of documentation, are private doctors, community doctors, and smaller groups, in terms of documentation and the robustness of their electronic medical record, are they, at a disadvantage to some of the larger groups? Have you seen that as a problem? And I just wanted to ask, in terms of Bonnie, in terms of the various threats that come to Affordable Care Act, how real, how dangerous is it? Because as we ramp up to do so much, can this all be undone in the short term?
Well, with regards to electronic medical records, one thing that I do want to point out is we did, some of you might be familiar with High Tech LA. Yes. It's a program I'm not directly involved with, but LA Care Health Plan was granted by the federal government an award to establish and operate the project, and that was designed to help individual and community physicians to provide them with education, outreach, and training, and to ensure that you have the health information technology assessment and information you need to make the most appropriate decisions when it comes to your vendors, how to utilize it, how to reach that meaningful use designation. So there are programs available to help ensure that you have the resources necessary to compete with some of the maybe larger groups that are out there. And we're partnering with the federal government to try to make that possible. Above and beyond that, I don't know if Bonnie might have some comments on it.
Okay. Well, in terms of the Affordable Care Act and being unraveled, I think you're referring to the court case that should be decided we're expecting it in June. I mean, we're very confident that the facts are clear that what the intent of Congress was is that people in states that didn't set up their own exchanges would be entitled to the same level, the same care that people in states who did choose to set up a exchange like California, that those people would be treated the same. So we think it's very clear and expect it to go that way. But we can't, of course, be 100% sure. But that being said, we see every day there's more and more understanding of the Affordable Care Act and the benefits, and it's the more every day passes where people are benefiting and letting their Congress people know how they're benefiting from this law, the less and less likely it is that this could be dismantled. I don't know if you all saw the Congresswoman who put out a request to hear horror stories from her constituents about Obamacare, and what she ended up getting were all these love letters about how her constituents were so helped by the law and by getting coverage. So I think Congress people will be hearing that as they go home for summer break, et cetera, and for Easter break too. So anyway, that being said, but Bianca, were you wanting me to comment on
Just with regards to the health information technology, I think part of her question was
Right.
whether individual and community physicians are disadvantaged. And I could speak to what LA Care here in LA County
Got the grant to
resources
do.
that are available.
Right.
But maybe
And
anything
also,
else.
we can help you too at the regional level if you're still having issues around EMR and have about your system. There was the money that came through HRSA, through the AHEX for individual to help the individual practicing physician. I think depending on how the budget goes, I'm not sure how that's going to be funded. But if community physicians are still seeking help with their EMR, then please contact me at the regional offices, and I will try and send you to resources that might be available to help. I know it's a big undertaking for the individual doc.
Yeah, and if I could just add one point, I will say at CMA, probably over the last year, we've heard more complaining about EHR vendors than I think we ever have, and it's and we think where a lot of the quality measures right now that are being used are really rating physicians on documentation more than actual quality of care and performance. We think where that's a problem, we think they're being disadvantaged by a lot of the EHR vendors right there. And we're hearing all the time, going to meaningful use, stage 3 I think it is now, with the sharing of data between other parties, that EHR vendors are saying, hey, well, if you want to communicate with that lab, we're going to need $10,000 to make that connection. So we think right now there really needs to be some restoration of sanity among some of the EHR vendors right now. As we get more and more payment based and fee for value and pay for performance, all that, as that starts making up a larger and larger chunk, we don't want to get to a situation where those larger groups with the capital to pay the vendor to come in however many days to add the 3 boxes to now you can get paid on your tobacco cessation education, which everybody knows you have to add 2 or 3 new check boxes to your system, which isn't cheap. And a lot of solo and small group physicians can't do that. So we think that needs to be something that's looked at going forward. And maybe that's one of the things that the CMS Healthcare Payment Learning and Action Network Super Team Strike Force. Sorry, it's a lot of words. I just have to make fun of it. But yeah, we're hoping that's one of their goals, and I think it is, if I understood it correctly.
Well, it should be, and I think that as I was saying, that I want this to be a beginning of a discussion, and at the regional level, we would be interested in having a convening and get issues like this that we can push through. Have CMS discuss, because I know that Secretary Burwell was just in the region, and one of the things she's talking about tying more Medicare payments to performance and value, is wanting to get the quality measures much simplified and coordinated across payers. So she's making that commitment to physicians that will be streamlined. But we could kind of jumpstart that and help at the regional level. Because our new, I wanted to tell you all about Ashby Wolf. Dr. Wolf has just started as at our regional offices in San Francisco as the new medical officer for CMS, and so she's very interested. She would have been here today, but this was her first week, so she didn't feel comfortable jumping in right now, but she wanted me to tell everyone to contact her, and I gave her, if there's going to be printout from this session, on my last slide there's her contact information. But also, if you want to contact her, contact me, and I'll put you in touch. But those are the kind of things we'd like to help you with.
Are you going to tell us more about your feelings, or CMS's feelings about risk adjustment? Because that's really where the rubber meets the road in regards to what's happening with minority doctors and patients. And I thought that there was at least early on, somewhat of a disconnect between health plans and CMS, the way that they see that.
Well, health plans are very interested in risk adjustment also because they want to get paid for the more difficult cases as well. So in that realm, you're kind of aligned with their incentives too. So there were discussions because there are risk adjustments that happen in payments from to the health plans after these first few years to see, because we want to make sure that people who agreed to participate early, if they do get saddled with more of the risk, that they aren't discouraged from continuing to participate. So there are risk adjustments that happen in the payments to health plans, and it's key to paying for performance is, do we want to pay for people who are of equal value in terms of how much resources they're going to cost the physician. So it's a key element, but I do think that this field has been being developed for 20 years. There's excellent measures available, so it's just a matter of getting them applied correctly and getting the data where you can then apply the risk adjustment. So physicians need to keep pressing for that, and I like very much what Dana said about the kind of analysis that Covered California is going to be doing, and the federal government also has been promising network adequacy regulations coming out soon. I don't know when exactly, they haven't put a date on that, but they are going to be issuing regs in that area too.
My name is Bruce Hector. I'm a family practitioner. I've been in private practice for 40 years. I've watched this whole thing, and I'm one of these 80% of doctors that Brett had on this little handout that didn't know what part of plans he was part of. To a great degree, it seems to me that all of this is premised upon managed care being the model that is applicable for delivery of services to these people. And to the life of me, I've been unable to find good evidence that documents that the managed care model provides better care. In fact, our own president once said that the Medicare Advantage program only proved to be of significant advantage to the insurers. Additionally, I have some question about risk adjustment. When my health plans or my IPA came around and started telling me about how to upcode CKD 2 and 3 and that they were going to pay me more, my response to them was, well, how much more are you going to get paid? And what percent of the additional payment am I getting? They didn't want to tell me that. So, and then I turned around and I said, well, you mean if I don't mark this, then you don't get paid as much? Yeah. Okay. I mean, well then to me, maybe that's a pass back for the $5 and $6 per member per month that I've lived with for the last 30 years. At any rate, do any of you have good documentation that managed care model beats private, solo, individual, or small group practice models in terms of quality of care delivery? Not cost savings, quality.
Yeah, that's it.
Who's
Well,
going first?
Who's going first? Anybody?
Well, I mean, if you want to speak to Bonnie, I know HSS has a lot of data on that.
Well, in thinking about that question, a couple things came to my mind, and then I talked to Ashby Wolf too, who's our new CMO, and she was talking about a pilot that was just completed in Fresno. It was on patient-centered medical, patient-centered medical home model, which showed increases in quality in terms of the measures that they had, which were better quality of care. Better coordination of care, and specific guidelines, standards of care followed. Using those kinds of measures, quality increased, and they saved a lot of money. So it was looking at better kind of team-based care. And I think that there are a lot of studies that show better quality of care under team-based care. If that's what, if you would like things to be shown on that.
No, you're talking about a team, but that team, I as a primary care doctor for most of my career have pretty well put together. Because I knew this guy,
Exactly.
that guy, and all of the other guys.
So that's the
And
model.
Now,
That is the model.
I got somebody else who is a health plan, who contracts with a bunch of specialists I never saw before. And then I ask authorization for somebody to see a specialist, and I get back this guy's name I never heard from. Don't know him, never heard of him, and I get nothing back in the feedback. In the old days, okay, when I was controlling that referral, if that guy didn't call me back that afternoon, he wasn't getting the next case. Okay?
Yes.
And that was quality control from my perspective. I'm lastly a little bit irked about all of this incentive pay. Okay? You know, I took a Hippocratic oath. And every patient I see, I'm going to give quality care for him, not for my pocketbook. And I'd like to not have to worry about my pocketbook. And you chip us down to the degree that that's what we have to do. And so I would like you to consider, one, the recognition that for 200 years, solo practitioners have been providing health care and have become family to lots of people. Okay?
Yeah.
Two, there is, to my mind, there has not been good research to assess the quality of that model. Yes, there have been outliers who've always taken advantage of those, of the system, and they're renegades, and they fall into those private practice guys. But for the rest of us, you know, I don't think we've done a good assessment of their ability to provide quality. As a participant in managed care for the last 20 years, personally, my ability to know what's going on with my patients has diminished. I can't go into hospitals anymore. They don't pay you to go into the hospital. You can't see a patient. You don't even know they're there until they come back 2 weeks later. And when they send you some information, the information just contains, well, this guy went to the emergency room. What do you go for? You know, I don't know.
Right. Well, I think what you're talking about is different. I mean, that model that you just outlined in the change of team-based care would be, you would have to test that. I don't know people who have looked at it.
I'd like you guys to test it.
Okay.
Okay? That's good research.
Would be good.
Okay? And if we really are interested in quality care for our people, then that's what we ought to be looking at. Instead of buying into corporate control and drug prices that are outrageous.
Right.
I think that some of where the discordance is that many of the people who are in the room who have cards in front of them, they are here because they have certain types of responsibilities. And I'm going to make the assumption, and we know what assumption boils down to, but I'm going to make the assumption that they do their jobs well. And some kind of way, when we talk about, once we started talking about healthcare as an industry, we cut out some of the parts that were already being done. I have a degree in medicine. I went back and got a degree in healthcare administration. I basically did that because I was running my own office and my major partner was my husband, and I got tired of him telling me I didn't know what I was doing. So now I had a piece of paper that showed I probably did know what I was doing, but I didn't learn anything that I didn't know all how to do. And that's this physician's frustration. You send some cherry-faced person or some witch with tight shoes on to my office to tell me what I have to set up. And after taking an hour of my time, where in theory I could have seen 4 patients, she's mad because I'm showing her the door, and I'm angry because she's just telling me to do what I'm already doing. At some point, we have to connect the dots. With luck, the old doctors will die out. So some of this will stop being a problem in general. But the people who are going through medical school, those who really want to take care of patients, they will have some of those same attitudes about why do I have to take time away from seeing my patients to go talk to Miss Cratchit. We have to connect the dots. I go back to, I want to be paid. I want to give my patients quality care. You deserve to know that I gave quality care because it's in the document. And I don't want to get to the 8th month of my patient's pregnancy, find out that her insurance has been changed, and now, out of nobody's control, she has to go have her baby 100 miles away. Those are the things that we need to fix in our system.
Yes. I wanted to shift the conversation a little bit to the consumer, understanding that as a provider, we are advocates for our patients. And irrespective of the monumental efforts and accomplishments in terms of having persons enrolled in Covered California, they're still, the most vulnerable populations are still not enrolled. And part of that is that because of the government's presence in the activity. And again, the vulnerable populations are by definition vulnerable in part because of their experience, their negative experience with government entities. I wanted to know for my patient's perspective, because I have had to spend a lot of time educating my patients on Covered California, and I see a lot of head nods in here, because again, we take care of the most vulnerable. I want to know what in the culture, the fabric of your culture, have you ingrained or interwoven a way to address the vulnerable population who is afraid to enroll? Because just as a colleague said earlier, well, we're going to get everyone enrolled, everyone's going to get insurance, and you're going to take it away. So in your efforts to measure things, are you also measuring your impact, influence in terms of the receptiveness to these vulnerable populations who need the services the most?
Yeah, sure. What you're saying is very accurate, and it's something that I know from the Covered California perspective, and DHCS and Medi-Cal will have their own. But for as far as getting somebody into a qualified health plan, we are trying to really be able to communicate through culture, so that folks know that what we're talking about is real, and that's difficult. We were able to get that first round of folks in who wanted to have insurance, and now we're tasked with getting folks in who were doing just fine without it. And there are all sorts of concerns that we have to address. We have to address folks who haven't filed their taxes in a long time. We have to address men who have been reticent in fulfilling their their paternal obligations as far as supporting their children. We have to as well assure homes that have mixed families, mixed immigration status, that know that you enroll with us, and we're not going to take your information and send your husband or your mother-in-law who is here without proper immigration status back to their country. There are all those things that we have to do. Part of that is doing the traditional broadcast advertisements and getting that message out. But I think that Cover California, I know that myself, as part of what I do, have recognized that we have to have boots on the ground. We have to really invoke community organizations that have both that the activist or the community organizer strategy, but also have a strong health background to be able to answer the questions and answer them credibly, so that people understand that that this is a real program that can have very solid, life-changing results for them, and that it is something that is going to be affordable. I know historically, I mean, we have big hurdles to overcome with, I think, the individual's trust in government programs. I mean, within African American communities, we know what's been done. I mean, we were the first to be used as experimental programs, and so by the government is right. And there are a lot of us who are alive in this room who were alive at the time that this was being done. And so we have to overcome that, and you're so right. But I think that it is doable. I myself have sit in barbershops trying to both persuade the barbers and the barbers' customers that this is something that you're going to need. And it's
agents of the government. Why should they believe?
Why should they believe me? But I try to as well explain to them what the ramifications are if you don't. That, yeah, you haven't filed your taxes. You want to make it even worse? No, you haven't paid your child care. Got that. But you need to take that step. This is a different time. This is the first time that your health care has been intertwined with your taxes. You try to explain to them that you think you're going to wait now and walk into the emergency room, as you have been doing for the past 10, 15 years, and say, well, I'm sick now, take care of me. No, I ain't got no insurance, but somebody else is going to pay for it. Well, those days are done. And so you try to show them that window, that picture, so that they won't be caught off guard when that day comes that they should need care, and they're in the emergency room and they start running. They say, okay, you want care, you got to give me your social security number, and we're going to start running that. And you're not going to be able to walk away this time because the hospitals wants to get its money back. So either you're going to be in Medi-Cal or you're going to enroll. Take your pick. So those are the stories. That's the message that we've got to get across, and it's a tough one to do. You're right.
We also just had another question that was burning that came over, and I know we're getting ready to, we have to start to wrap up, but this one was a burning question. That it was a segue, or it's a part B of one of the questions. We have Twitter and so forth going on also. So the question was, if Covered California is a hybrid, private and federal, then why can't the contracts be transparent, similar to Medicare and Medicaid, where the fee schedules are transparent, but the Covered California contracts are proprietary property and were delegated to the insurance companies?
And we're talking about the contracts between Covered California and the insurance companies?
No, the health plans and the physicians. Okay. Why can't those be transparent if it truly is a government agency, just like Medicare and Medicaid?
Do you want to answer answer that, or
Sure.
I can?
I'll try to tackle it from Blue Shield's perspective. The simple answer to not publishing a physician's reimbursement is our basic premise that our contracts are confidential. Neither party is entitled to share details of the contract because it's really between those two parties. Now, that doesn't mean that we don't make our fee schedule, if you will, transparent. And I am referring to our PPO product now, which is basically not through an intermediary like an IPA or others. And we do make it transparent. We put it on our website, and physicians who are contracted with us, or even if they aren't, are welcome to go and check out our fees on our website. Now, that's for our PPO. That's not, I'm not speaking HMO here. But we do try to provide transparency from that, but we're just not able to, divulge specific details of a contract between a physician group and us because we do feel that those are confidential.
So would you like to answer, please?
I was just going to say that the one other thing that we deal with on the health plan side that I don't think most physicians have been made aware of is there are certain regulations on Covered California in terms of any profit or losses, the amount of exposure we have either way when it comes to profit or losses. And because it's the first year of the program, Covered California wants to ensure that no one health plan is disadvantaged by having a disproportionately ill or disproportionately healthy group and thereby making a obscene profit or going under as a result of this new experimental program. As such, we're somewhat uncertain as to what our own funding looks like at the end of the day. I know the latest data that I at least received from our CFO and chief actuary was, and this is reported, I believe, by Covered California, I believe publicly, but it's something like 40% of what we originally paid will eventually be taken back from LA Care based upon the risk scores of the members that signed up with us. So, that said, we've paid physicians at a certain level. We've paid our physician groups at a certain capitated level. We're looking at having 40% of that money taken away from us at the end of the day. Now, we're not coming to you right now and saying, hey, we want that 40% back, but that's something that we can't necessarily know until these reconciliations take place after the fact. It's very complicated, and I wish it was a simple black and white answer we could pass through. And we are talking about doing things to try to be more transparent, like paying you at a percentage of our premium. So whatever we receive from the state, we pay you at a percentage of that. You might disagree with it and say, I don't want any part of it. That's fine. But it's very upfront and saying this is a percentage that you're getting out of what we got total. Because we've got to pay for things like, let's just say, acupuncture or whatever benefits might be provided outside of what you're specifically being paid for in your capitation payment. So we are looking at different things like that to try to make it more transparent. But as this is the first year of the program, I think a lot of that is still being worked out.
Thank you. We're going to be wrapping up, but I would like to leave the last comment to Dr. Baker, and then I'm going to summarize, and then we can all enjoy the rest of our evening.
Thank you much. Thank you very much. That's a lot of pressure. First of all, I'd like to thank ABWP once again, as Dr. Williams said, for a wonderful And in part, this is wonderful because typical of what ABWP does. Hopefully, this is really the beginning, of something that and a conversation. So I'd just like to say just a couple of things so that we can all go. So I really like the issues. Issues are structural issues, and the issues are issues relative to policy and transparency. So when we go back to the question about evidence-based policy, right? Because I think what's happening here many times, it's the policies of the health plans and others that are not totally transparent to us in terms of moving forward, right? That playing field. And so I go back to where's the forum by which physicians are able to help produce the evidence for evidence-based policies. Thus far, we haven't been part of that conversation at all. and going forward, and it's important because of the assumptions that we're making. So one assumption, and we heard from one of the representatives of the solo small groups that have been, out in the fields, in the vineyards, right? Well, one, the reality is, and this assumption that finally they'll all die out, they'll go away. Well, today, as some of us know, out of that safety net population, out of that covered California population, 50% of the providers for those patients are solo small group private practice providers. 50%. 50%. 50%. So it's not a small marginal group. This is a very important group that's not being addressed today at all. And we go back to reporting and infrastructure. Infrastructure is more than each EHR in terms of reporting. The high-end groups, I'll talk the commercial groups, I won't name them by name, they've had enough profit where they can reinvest, and they have the benefit of significant infrastructure, and they can report very well. They can report to Anthem and everybody else appropriately. Solo small group, that infrastructure is not there. And to understand the importance of the infrastructure, realize that for the FQHCs in the same population, they've gotten over $800 million for infrastructure. So I think it's important. And they're still having problems reporting. So if we're not in the business of starting to look at, well, what can we do? How can we invest in these 50% of the physician population in order to help them help us, with the patients? I mean, that has to be a consideration. How do we do that? Now, even with the EHRs, one of the things that wasn't said, we ran out of money. So everybody didn't get the opportunity to even go forward in terms of meaningful use. Right? Everybody wanted to go for it. We just ran out of money. So even with the EHRs. So again, I think the real issue is, bringing people back in, having that discussion going forward, having wisdom going forward, and because, within, and this shouldn't become a surprise, because going all the way back to the first attempt at reform with the Clinton plan, right? There was a designation, essential community provider. That designation, I think most people were taught, they fulfill that designation, essential community provider. That's very narrow in covered California. Many of the people that would be essential community providers are not designated as such. And that's where the trust comes from. That's where all the other things that we talk about in terms of relationships and everything. So it's really thought about. And in terms of essential community provider, also there's a part of the regulation is that essential community provider should be compensated similarly to someone who's not an essential community provider. Of course, we can never know that because, well, there's certain regulatory issues, in terms of confidentiality, but it's very clear that I don't believe all of the providers, these essential community providers, people in those communities, are being compensated at the same level, but we don't know. That's for the regulatory agencies to see and find out. I'll just leave it there in terms of other things. Thank you.
Thank you so much. Now, wasn't that worth it? Well, at this point, I am going to have to wrap up, and I do acknowledge that we didn't have enough time, but I think we can all agree that it was a very informative and productive discussion. I want to thank all of our guests. I want to thank all of the participants. And again, I want to thank California Medical Association, the Network of Ethnic Physician Organization. I want to thank Golden State Medical Association, because as you know, it takes a team, right? And so we want to thank all. And also we want to thank Mr. Raj Traylor in the back and Mr. Steve Turner. So I want to say thank you to you all for coming out. And it just sounds like, just to sum up some of the buzzwords that we continue to hear over and over again, is one of the things I heard was Affordable Care Act is
free, thanks to the following sponsor.
That it's not
programs like Grammy Amplifier are incredibly important.
Getting to collaborate with was quality care does not necessarily mean documenting in a chart. That's another thing that I heard. It doesn't necessarily synonymous with delivering it. The other thing I heard was the narrowing of the networks and how that can negatively impact the underserved and basically putting their doctors out of business. And then finally, as Dr. Baker intimated, with the electronic health records, that's just another example of, again, how if quality is going to be measured by documentation, how it's not a fair playing field for the solo practitioners and small groups who are such a big part of this healthcare landscape. Thank you all for coming out, and we'll see you at the next discussion.